Good morning, good afternoon, good evening, everyone. Greetings from the Global Alliance for Medical Physics, Education and Research. I am MD Jubairul Islam, founder and executive director of GAMPER, and it's great pleasure to welcome you to today's insightful webinar on treatment plan checks as a risk management tool. This event is made possible through the collaborative efforts of professionals across various regions. We are truly inspired by the tremendous global response to this event, with over 1,100 registered participants from 85 countries, representing 24 countries from Africa, 31 countries from Asia, 11 from Europe, 7 from North America, and 6 from South America, and 2 from Oceania. Now, I am also delighted to introduce our moderator for today's sessions, Dr. Akhtaruzzaman. Dr. Akhtaruzzaman is a Chief Medical Physicist and Radiation Safety Officer at Evercare Hospital, Chattogram, Bangladesh. He holds an MSc in Medical Physics from Ghana University, Bangladesh, and earned his PhD from Mary Skolodowska-Curie Institute of Oncology in Poland. Dr. Akhtaruzzaman began his career as a faculty in medical physics at Ghana University, then his clinical expertise at Ahasani Mission Cancer and General Hospital. After doctoral studies, he served as a senior medical physicist at Labit Cancer Hospital and also holds guest faculty at the University of Colombo in Sri Lanka. Dr. Akhtaruzzaman has begun involving in teaching and research in medical physics to MD, FCPS residents of radiotherapy. He is also involved in supervising and guiding postgraduate students in his field of medical physics. He has been engaged in collaborative research initiative at the University of Western Australia, Perth, in Australia. An active leader in his field, Dr. Akhtaruzzaman is a president of Bangladesh Medical Physics Society and served on the Education and Training Committee of AFOM, and where he also acts as editor of the AFOM Pulse and SCMPCR newsletter. He works as dosimetry treatment planning, quality assurance, and development in medical physics education practice in South Asia and beyond. Now, Dr. Akhtaruzzaman, the virtual floor is yours. Thank you.
Thank you, Joel Islam. It would be grateful if you share that. Yeah. Today we have a panel of expert, Dr. Ahmed Shoaib. He is an associate professor and consultant at the Department of Radiation Oncology, Minofio University in Egypt. Dr. Ahmed Shoaib is a clinical oncologist and a nominated associate professor in the Faculty of Medicine, Minofio University. He earned his PhD in 2019 and has since been actively involved in both clinical practice and academic teaching. Dr. Shoaib received extensive training in advanced radiotherapy techniques, primarily in Egypt, and further enhanced his expertise through specialized programs in several European countries, including Belgium, Denmark, Italy. Oncology, consultant of radiation oncology with the Saudi Commission of Health Specialists, reflecting his recognized professional standing across the region. And today, we are very happy to have Professor Tomas Kron, who personally I know him since many years, and he is also one of my mentors. I am very, very delighted to have him today. So Professor Tomas Kron was born and educated in Germany. Since completing, he migrated to Australia in 1989, where he commenced his career in medical physics, especially in radiation therapy. Later, he moved to Canada and served until 2005 at the London Regional Cancer Centre, where one of the first tomography units were installed. In 2005, Professor Thomas returned to Australia and became the principal research physicist at the Peter MacCallum Cancer Centre in Melbourne. He is a certified in Europe. He holds academic honorary appointments on a professional level at the Monash University, RMI University, and the University of Wollongong. He has a diverse interest in medical physics, including dosimetry of ionizing radiation, image-guided radiotherapy, clinical trials, education of medical physicists, many more. He has published about 250 papers in peer-reviewed journals. Years, Professor Thomas has maintained an interest in education reflected in about 100 invited conference presentations, consultancies for the IAEA, and involvement in workshops in training, Australasia and beyond. He serves on the editorial board of several international journals. In 2013, he was awarded the Distinguished Services Award of the Australasian College of Physical Scientists and Engineers in Medicine, ACPS, and nominated as one of the 50 medical physicists featured in the International Conference of Medical Physics ICMP in Brighton, UK. In 2014, he was awarded an Order of Australia Medal (OAM) for services to medicine, service in education. Currently, he has been servicing Peter Mac as the Director of Physical Sciences. So I would like to welcome Professor Tomas Kron to continue his presentation. Thank you.
Thank you all so much for the kind words and the warm welcome. I am absolutely delighted and I'm really honored to have this opportunity here to speak a bit about plan checking and about really medical physics. Before I get started, let me please share my screen and make sure that you all can see the screen here.
We can see you.
Yep. So here,
all right.
Hopefully will
it's all right.
My screen. And what I'd like to do, you can see here already from this slide, is really set sort of a big picture of plan checks as a risk management tool, and thereby really reflect on the role of medical physicists in cancer care and medicine as a whole. I also should work I'm trying to present here is really not just mine. It is really reflecting 40 years in the field and the work of many, many other colleagues, in particular here in this context, Keith Offer, Chris Fox, and Lottie Fogg. Before I get started, this is the place I'm coming from. It's Peter MacCallum Cancer Centre, a rather large radiotherapy centre of a public nature, so we treat patients for free. We have 16 linear accelerators, 1 gamma knife, and 4 superficial units, and you can see here most other bits and pieces which are expected in a rich an environment, in a resource-rich environment. So I feel very, very privileged to have this opportunity to contribute to the services and try to take all this one context of patients, because patients are really the same all over the world. They are suffering, and our role as medical physicists is trying to help bring technology to a use that we can minimize the suffering of people. This slide also allows me to provide an update on my conflict of interest, or the potential conflict of interest, because it is always important when you listen to me speak that you know what I may be saying or why I say some things. I don't think I am influenced in what I say by our collaborations, research collaborations with varying medical systems, Vision RT and Reflection, but it obviously is something which is a grain of salt. When I talk about radiotherapy treatment plans, then I just recognize that a treatment plan is really the main thing which makes radiotherapy a personalized treatment modality. Every patient, and we have individual patient information, and combine that with whatever we have available in our center in order to optimize the approach for the treatment planning and then the delivery. Between the treatment plan, though, and the treatment delivery, there is typically a check, because these treatment plans can be very simple or can be very complicated. But in any case, they are the primary source of the way patients will be treated. So the ultimate documentation of radiotherapy intent and approach does clearly require some checking. And that's what this presentation is all about. I should also mention that in the context of Australia, the treatment planning and the treatment delivery is performed by RTTs, by radiation therapists, and their physicists are sort of sitting a bit as the meat in the sandwich, doing the treatment plan checks, and also obviously setting up their planning system and doing quality assurance for the treatment delivery. It is important to really realize that these plan checks are really a multidisciplinary event. The overall cancer care in radiotherapy is multidisciplinary by its very natures. So that makes also our plan checks informed by other professions and patients. It also is probably worthwhile mentioning that in the context of modern radiotherapy, adaptive radiotherapy, we are doing more than one treatment plan. We are doing a treatment plan for the patient as he or she presents on the day. So that also would mean that we do need to perform more than one treatment plan check. And these are the objectives of my presentation of the next 40 minutes or so, that I would like to just give you a bit of a background for the physics plan checks, in particular in the context of our center, explore where these plan checks fit into a radiotherapy workflow, and analyze then the benefits which come from these plan checks. Do they really make a difference? I should already now point out that this is not a recommendation for everyone. What we do as plan checks depends on our patients, our treatment equipment, our professionals, and a whole lot of other things, which I will try to explain in the rest of the talk. I also would like to start by something rather simple, an anniversary. There's a 1-year anniversary of our college's position paper on pre-treatment patient-specific plan checks and quality assurance in radiation oncology. And all I'm trying to say with that is that it's really never too late to think about treatment plan checks and try to put some framework around these treatment plan checks, which can help guide professionals to do the right thing. It also helps other professions to say, oh, these physicists, they know what they're doing. We all know that as medical physicists, but others may not. Publishing that, developing guidelines, and so on is obviously important. And our position paper in radiation in Australia is obviously not standing alone, but is building on a whole lot of other papers. And I'm just sort of showing here 4 AAPM documents, which are also concerned with treatment plan checking. But since I have gray hair, I might as well wind the clock back about 30 years to a paper in 1997, which was the first paper I was involved with about treatment plan checking as such. And at the time, we analyzed about 2,000 plan checks over about 2 years and could identify that we had, in terms of errors, about 10 plans did 10% of plans warranted intervention, but only 6 major errors were found. So you can see here a summary of these 6 errors there. They all would have really resulted in a very significant patient problem. So at the time, we would say that the rate of finding major errors is about 0.3%, or basically 1 in 300 patients will directly benefit from these treatment plan checks. That was 30 years ago. How does it look today? These were very simple plans. They were typically APPA treatments or 4-field boxes, no IMRT, nothing fancy overall. We also at the time took the opportunity to check in Australia who is actually doing treatment plan checking in Australia, New Zealand at the time. And we found that 20% of centers did not do any checks at all. I really hope that that's not the case anymore, and that all treatment plans which reach the patient will have some sort of check, hopefully also by a physicist. At the time, we also found that we had in Australia a very large variety of different treatment planning systems, none of them really related to the major treatment delivery vendors at the time, which basically sort of shows you already what a large variety of different equipment we were using, and also that a lot of material and a lot of work actually was done in a multi-center environment. What was the workload like at the time? Well, it was quite variable. This is the workload, physicist hours per week per LINAC in terms of treatment plan checking. And you can see that the 30-odd hospitals we surveyed at the time had workload from virtually no time spent on treatment planning, and these are the 20% of people who didn't do any treatment plan checks, to up to 1.5 EFT, or half a physicist per LINAC was actually doing treatment plan checking, but the mean was about 0.5 EFT, 0.15 EFT. So that basically meant that 30 years ago, treatment plan checking was about 10% of our workload. How has that changed? Now, we're looking 30 years forward, and this is data of today. Obviously, we have a lot more fancy ways of recording data in our software and analyzing here the treatment plan checks or the patient treatments from 2000 and I think that's 2019 to 2025. And you can see there's sort of a slow increase in terms of the workload. And these days, our work is really very much determined by treatment plan checking. If one looks today, and I'm trying to build sort of workforce models, trying to tell our administration what physicists do, how much time do they spend on work. And if I look nowadays at the work as physicists undertake it in our institution, then I will find that the work related to equipment, that's basically machine QA, that's output checks, calibrations, and so on, requires about 11 EFTs. And that's for 16 linear accelerators, gamma knives, and all sorts of other pieces of equipment. So really not, well, it's a substantial amount of work, but it's probably about half a physicist for equipment. If I look, however, at patient-related work, this is more than double the machine-related work. And that, I think, is a very important message we need to get across to patients, to clinicians, and to all sorts of people, which matters directly for the patient, and actually in our hands more. And that is, I think, an important message, probably the most important message of this presentation overall. But let's sort of see if we can analyze that a bit more. Nowadays, we don't have any more spreadsheets, as we reigned superb in the late 1990s, 30 years ago. And you can see that virtually everything these days is VMAT. We treat about 100 new VMAT cases per week, and typically sort of about 30 other treatments. So 70% of our treatments are VMAT. The plan checks of physicists are also much better organized than they were 30 years ago. These days, we have a purposely written software program called QA Nucleus, which is a database and a check program, all web-based, where we can record the data of the checks. And you can sort of see this is a very intricate checklist. It's even color-coded, so you can see plan data, CT data, other scans and treatments, volumes, LINACs, and so on. All this is really there for physicists to work through. You can see already this is a very long checklist. No wonder that a lot of time is spent on that. But obviously, plan checks are these days, certainly in Australia, non-negotiable. The Code for Medical Radiation Protection in Australia, which is basically a legal document which we all have to work with, basically says that our CEO, our chief executive officer in the hospital, must ensure that treatment plan checks are actually performed, that there's a patient-specific independent calculation of monitor units, and so on. So there's really no way that these checks can't be done. They also really help for reimbursement, because in order to get paid for a treatment plan in Australia, or to get paid well, you do need to have a final treatment plan validated by a radiation therapist or medical physicist. And again, a quality assurance program needs to be in place. So we have really also sound economic and sound legal and regulatory frameworks, which basically enshrine that medical physicists should do treatment plan checks. I want to now give you sort of a bit more information about this treatment plan checks as we perform them here. This QA nucleus database, as such, is not just there to record the outcome, but it also provides them a summary sheet which can be attached to patient notes. It is allowing us to look at the treatment plans, revising our checklists and updating it, measuring if it actually makes a difference, and hopefully by distinguishing between different professions, by distinguishing between different tumor strains, can sort of say, do these checks make a difference in lung cancer, in head and neck cancer, in gynecological malignancies, and so on. So how effective is this plan checking? And last year, we basically tried to identify that, put together a group which actually analyzed 12 months worth of physics plan checks, looked at the number of replans, basically how often was a patient replanned due to a physics intervention, and look at the number of plans which were discussed. Basically, there was some sort of feedback to radiation therapists, to oncologists, to someone, in order to just start a quality improvement loop. And we performed a risk assessment, as per the title of my talk, a risk assessment using some sort of modified TG100 approach. So, how many changes were there? Well, we had replans requested at a rate of about 1.3% of their patients where we did a treatment plan check, or about 100 patients per year. So the number is actually higher than it was 30 years ago. It's now about four times higher, where an request was made based on something which obviously could be improved overall. And in addition to that, about 3 times more, there wasn't any change to the patient treatment plan, that there was some discussion, some recommendation about the way the treatment plan was performed. So I leave it up to you to judge if this sort of rate, 100 patients who had an improved treatment plan, if that warrants the work of some 20 physicists. More interesting, or more sort of general, is also the risk assessment as per TG100. And I will tell you a bit more about the risk priority number later, but it basically sort of says the higher this risk priority number is, the more important it is really that these things are checked. And these are VMAT treatments or IMRT treatments, these are SRS treatments, and these are the sort of assessments in terms of risk priority, what should be really checked most likely. This is obviously only really valid for Peter Mac. This is not something which anyone can take and say, artifacts correctly handled in the imaging is really, really important. It is something which is really a domain of the medical physicist. That may be not applicable in your environment if you do different treatment planning. But for us, it really is quite interesting to see that the most important checks of the radiation oncology physicist are pertaining to imaging. And that's probably the second important take-home message here, that we are getting to a point where the different specialties of medical physicists, the imaging, the therapy physicists, the nuclear medicine physicists, they do need to talk again with each other. They do need to come together. And what we do in terms of radiation oncology medical physics has the most impact if we actually learn from our diagnostic colleagues. We did this a formal multidisciplinary review of our checks, at least from a physics perspective, also to try and consolidate the workload, reduce the workload, and reduce the overlap between checks of different professions. RTs do checks, ROs do checks, physicists do checks. And we came up with a process where we have two different categories of checks, where standard treatments, and you should have told me 15 years ago that I would say IMRT and VMAT is standard. Nowadays, it is certainly in our institution, but that does not mean that it is everywhere. Other institutions may say our VMAT is category 2 and is actually high risk. In our cases, we feel, based on the analysis of what we've done, that we can relax our QA in these processes a bit, but that allows us to focus more on treatments where things really matter, which are the stereotactic treatments, gated deliveries, as such, special clinical trials, and of course, pediatric treatments and re-irradiations. It's probably really re-irradiations with the physicists. We need to bring in the previous images as such a particular important role. So now you can see also that by trying to understand what we are doing, trying to analyze where does it make a difference, we were able to reduce the workload considerably. By assigning to a very sometime in these quality assurance tests. Well, this has suited Peter Mac, or at least I think it has suited, encourage you to look at what you are doing and how effective the work we do. Many different flavors, and many departments have a variety of these, not all of them typically. We are sort of in the luck, we are really lucky that we have an opportunity to sort of look at all these different tools as such. And we find that understanding a treatment plan, or basically a treatment plan check, is probably one of the most important tools for patient-specific quality assurance. But we do arc check measurements, we do in vivo dosimetry, we also do some EPIT dosimetry overall. But again, it is really the physicist in an institution, by looking at all these different options, to decide what is the most appropriate thing for a particular patient, for a particular situation, for a particular treatment plan. So it is now important to sort of look, probably not just as our own experiences, but also other experiences. And I really like the work done at the IROC, the center, which does quality assurance for clinical trials in the US. And Stephen Fry's paper is really one of the classics, which basically looked at how well does patient-specific QA using a phantom measurement, like an arc check system, how well does that correlate then with measurements which then IROC does as an audit end-to-end of patient-specific QA and of potential treatment outcomes. So you can basically take this IROC use as the patient treatment as it would hit the patient. And institutional QA you can take as the patient-specific QA as such. And you can see that the correlation matrix really is not all that well. Obviously, the institutions would only go forward with an audit if they think that the treatment will actually pass. However, that does not mean that it actually passes. And a lot of institution-specific QA did not detect very fundamental errors. So it is really something where we do need, as physicists, to come together and think hard, how can we actually improve our practice? And one way of doing that is actually to introduce artificial errors. And the artificial errors, and one method of doing that is, for example, this program Seafarer, but there are a variety of other ways how this is doing. And Ben Nelms has published a lot of work about it. And it basically just means you take a treatment plan, introduce an error, and then see, does your patient-specific QA actually pick that error up? And we had also our institution participated that, and I can say we certainly didn't pick up all the errors as such. But it does highlight our perception about what should we check and why is risk management important. And that basically led us to these TG100-based approaches to our treatment plan checking, to our patient-specific QA processes, where we try to prioritize what we do on how severe the impact of something would be and how high the likelihood of something is going wrong is actually going to be. And that basically helps us to focus the resources, and everyone has limited resources, on the most important aspects as such. A good way of looking at least at the frequency of things which happened is to look at past things which actually led to accidents.
এবং মানে আমার যদি মনে হয় যে এটাকে ধরো লিম্ফোসাইটিক ফ্যাক্টর খুব একটা ইনফিল্ট্রেশন।
Thank you. And this is a good publication. There are many of these publications from the ICRP, the International Commission on Radiological Protection, or from the IAEA. And you can typically find that treatment planning and dose calculation is responsible for about 30% of these errors. So I think by looking at treatment plans and doing treatment plan checking, we're clearly looking at one of the bigger contributors to patient errors. We often add in risk prioritization a third dimension. How easy is it for a problem to go undetected? And that's sort of called detectability. Clearly a potential problem which is very easily spotted at the treatment unit is less important to check because there will be a final check before that. But then something which we possibly couldn't check, couldn't pick up otherwise. Like, for example, if the output of a machine is wrong, it's certainly not something image guidance at the treatment unit will be able to pick up. So detectability also comes in there, and that basically leads to this likelihood times severity by times undetectability. I prefer that the easier something can go unnoticed. I just multiply these. I assign a scale from 1 to 10 to all of these: severity, likelihood, and undetectability, and basically multiply that, getting a number between 1 and 1,000, which gives me then more or less the redness of the work done. There are
Thomas, you're not.
Thank you. I don't know. Someone must have unmuted me. Can you hear me again?
Yes, please proceed.
Yes, sir, we can hear you.
Excellent. Good. So basically what we tried, there are many different papers out there which use this concept of TG100, or basically failure modes and effect analysis, where one multiplies the severity of a potential incident, the likelihood of a potential incident, and the likelihood that it can go undetected, multiplies that, and then calculates what is important, what should be part of a chart review overall. And this is just one of the papers there, which shows that. But there are papers for virtually all treatment modality which show how this concept can be applied. However, it is always important to say this is working here for the University of Washington Medical Center. This is not working for us. And when we tried to compare what others have done for plan checks in terms of prioritization and our own prioritization, we see typically sort of a broad coincidence, but certainly not identical results. So it is something everyone needs to do for themselves. So this is basically following these reports, and I really should encourage everyone to have a look at this task group report 100, not to follow it, but to appreciate that as physicists, we're not just doing something, but we are also asking, does it work? And we are asking, how can we judge if it works? And how can we prioritize how we look at our resources? And this is really what this document is all about. They all start by analyzing how a process actually works. So that would be a process map. And all risk management basically just initially means we sit back and say, how does actually something work? And you can see here that for treatment plan checks, you have all these different process maps by different investigators. Again, there's a whole variety, and it doesn't really matter what you do. I think the most important thing is really that one does something. And it does not necessarily need to be a failure modes and effects analysis, which is basically looking at what's the process map, what can go wrong, how likely is it, and how severe are the consequences. That's what we've talked about. But there are also other ways how risk management can be done. And whatever you choose, it is a method of doing two things: to check how effective is what we are doing, and to check how can we improve or make sure that what we are doing is the most effective it can be. This is sort of an interesting, one of my favorite papers, where these people basically looked at the score number, and this is this number between 0 and 1,000, and they looked at their scores overall, and they looked at what really makes a difference. And you can see that in this case, the severity, which is the dots, the crosses, they really determined more or less in their analysis what the risk priority number came out, or what should be prioritized. And that's sort of an interesting outcome, because it basically would say that physicists should check what is the most severe problem. We should probably not be too guided too much about the detectability, which is always roughly considered the same, independent of the overall score, nor should we worry too much about the likelihood, but we really need to look at the severity in order to guide what we are doing. And I think that's not a huge surprise. Most physicists would probably do that, and in their plan checks, prioritize what is the most severe impact. Let me try to get back to treatment plan checks and try to look at the overall patient pathway in external beam radiotherapy, and try to see, can we use this risk management approach here in this pathway. So this is basically a process map, a very high level process map of a patient flow, from the clinical evaluation through the therapeutic decision, through patient immobilization, emergent management, and so on. One important message comes from this straight away, that these processes also involve a variety of bits and pieces of equipment. And that's obviously where physicists typically come in as such. And usually, in virtually all institutions, the equipment comes from different vendors. And this is basically our institution as such. We have immobilization from one vendor, who's the same, happens to be the same vendor for some of the emergent management tools, like the compression belts, but then imaging for planning is somewhere else. And if one looks at all the associated varieties as well, then we can see that we have at least 6 different vendors in our patient treatment environment. Now, unfortunately, the multi-vendor environment, each time data is moving from one vendor to the next, from the treatment plan to the record and verify system to the treatment unit, each time these handovers have to be done, we are actually increasing risks. And that is clearly our experience, and this has been also documented in the literature. We had over the last couple of years, a couple of major issues, and they all were related to some sort of handshake between different vendors as such. If I say all, there were 2, but nevertheless, it is quite interesting to see that the problems occur in a multi-vendor environment. A different way to look at that is also that in our CT scanners, when we do QA, and we went back 5 years, looked at all the different things which could go wrong in our CT scanners. For treatment planning, the vast majority of problems we found were related to lasers and to a flat couch top. Now, obviously, these 2 things are not the things Siemens, Philips, Canon sell. They are different vendors. And it's the interface, or the where we try to put different pieces of equipment together, which really lead to an increased risk. And it's clearly something where we, as a team of physicists, try to be particularly vigilant. In software, that makes particularly sense, and it's fairly obvious, because each time you upgrade the treatment planning system, you do also check that the record and verify system is actually still compatible. Each time you upgrade any piece of software, you need to check all the other bits and pieces as such. And in the context of adaptation, the treatment plan checks, as we discussed before, obviously need to be done over and over again, which sort of allows me to then look at the plan check in these environments and sort of see how the plan checks multiply over and over and over again. And obviously, in that context, the likelihood goes up and up and up and up, because if I have 30 plan checks in a treatment rather than 1, then the likelihood of something going wrong is much higher. On the other hand, the severity may go down because each plan only affects 1 treatment. Nevertheless, it means that if we have these many plan checks, and we have to do checks that many times, we do need to engage in some sort of automation. And artificial intelligence is clearly a tool which can help us in this context. And I've just given you here a couple of papers which I think are particularly relevant. This is one of my favorite papers here, which is an early paper which just sort of looks at all the links between artificial intelligence and radiation oncology. Quite a nice sort of summary. But obviously, this is 4 years old and as such already nearly out of date. At Peter Mac, we are also looking at automation, and Keith Offer, who is the physicist who has done a lot of work in this space and is a brilliant programmer as well, is attempting to develop a machine learning model to predict when planned QA fails or how the outcomes come. One of the biggest problems really is that most treatment plans are actually really quite good. So we do not have a lot of true fails to learn from, which makes that difficult, but sort of a difficulty which we probably are quite happy of, because we obviously don't want a lot of true fails as such. But for plan checks, we really try to automate whatever we can. Data entry, dual entries should all be really automated as such. Report submission should be automated as such, and the management of that in terms of informing people that work needs to be done or alerting people to work to be done should really be automated as much as possible. And I think I certainly see one of the main responsibilities of physicists these days is really to help with this sort of automation. But keep in mind, or it's always important to remind myself as well, that artificial intelligence, at least at this point in time, is not truly intelligence, and we should not try to automate what we can't. And human reasoning and oversight is, I think, still a tremendously important part of the chain. So I don't think we need to worry about our jobs at this point in time. Very simple things of automation is, for example, notifications. So every day we now get an automatic notification, which basically tells us how many treatment plans checks are completed, how many have a first check done, how many are incomplete. And then we have some tools to drill down which checks are they, which campers are they pertaining to. Clearly very, very helpful in order to guide our clinical practice. Scripting is obviously really, really important. And you wouldn't buy a treatment planning system these days anymore if you don't have some sort of tool to automate things. However, again, I think it is quite important to do that all, not just at an ad hoc way to say, oh, wouldn't it be nice if we could do such and such and such? And then someone else finds the script, does it potentially wrongly. So I think it is quite important to look at governance of these processes, governance of the automation overall in a multidisciplinary team and environment where we ask, is the idea really a good one? Does it add value? What resources are required to do that? Assign responsibility, including of testing of new scripts, and then only deploy these these scripts, these automation processes in reality. Because it is so easy to create a black box, which one clever programmer knows how it works, but others may then apply incorrectly. So these are the number of usages of Eclipse scripts. We use Eclipse. These are the counts, and these are the months overall. And you can see that per month we use scripts or automation on a small scale. Some of these scripts are really, really simple as such. But these scripts are used thousands of times per month, are used thousands of times by different professions overall as such. And you can sort of see here, these are all the scripts we have enabled. You could write many, many more, and you can download many, many more from vendors' web pages, from lovely colleagues' web pages, from GitHub, and so on. But I think it is important to only select the ones which are really useful and test it, and also delete the ones which prove to be not used. So here you can see the number of script executions, and you can see these are going in the very high thousands. One particular script I wanted to show you, because we're talking about plan checks as such, which is the plan checker script as such. And you can see since its introduction in 2020, it has really, in terms of use, increased really dramatically. And all that script does, oh, well, not all, but the script basically goes for treatment plan checks. Is the slice thickness of the CT scan appropriate? Is the right dose calculation algorithm used? And all these sort of things which are very easy to check if you know where to look and if you can work with numbers. So by actually using this script already in the treatment plan process, before you actually submit the treatment plan for checks, so you can here see sort of typical things which the plan's script does. Looks at a whole variety of things like jaw tracking, the normalization points, bolus use, and so on, and provides warning if non-standardized namings are used, clearly something which makes standardization of treatment plans and so on, and a lot of things really much easier. And it seems to work. Again, it's difficult to decide, is that the cause of the reducing intervention rate, that after the plan check was introduced, that the number of events where physicists find problems goes down, or is that just something which happens with time? We do not have the causality of that approach, but we certainly can see that. Let me finally finish with showing you what I've shown you right at the start already, where the RTs provide the treatment plan, the physicists do some QA, and the RTs deliver the treatment. Looking at this decreasing workload and the plan checks, which are done now built in with that script here at the planning stage, do we really still need the physicist? I already told you that we have really no idea, or we can't really demonstrate that there is causality of these additional checks here, that this is less required. But we also have really no idea if this is the plan check script really. Oh, we do know the plan check script does not check everything as such, and the checks are still really valid. They're particularly valid because nowadays we are not looking at such a linear workflow anymore. We have already talked about adaptive processes where things happen over and over again, where contouring may change due to image guidance as such, where we have other professions involved as such. And the physicists now appear at many more times in the treatment planning process. Maybe another talk I can give, or someone who's better qualified from our institution can give on motion management, will tell you that looking at 4D CT scans and actually checking them is one of the most impactful things a physicist can do. So these physics checks and the involvement of the physicist into that treatment planning chain, or the patient overall chain, is really something which occurs at many different points, not just in this plan QA check. And obviously, one informs the other. So when should a physicist check? At the moment in our institution, the physicist is the last one in the chain, which has advantages and disadvantages, because we duplicate, at least at times, some of the checks others do. We've tried in the review process, which I showed you before, to minimize that overlap, or at least reduce it where it does not add value. On the other hand, some duplication is really desirable, and everyone who studies radiation safety knows of the defense in depth concept and the fact that important things really ought to be checked multiple times. Redundancy is our friend. It's not only our enemy. In this Swiss cheese example, really sort of is always used, where we try to make sure that the holes don't align as such. And the physicists bring a lot of very unique things to the table. We know about the dose calculation algorithms, know imaging modalities, and the imaging really comes up over and over and over again. And it's the physicists who, as part of their training, probably have more imaging knowledge than other professions. But we probably need to sharpen that even further by working with our diagnostic colleagues. We have an appreciation of motion, geometry, and so on, and clearly have some oversight over the multi-vendor environment, which we talked already about. So the role of plan checks then really lead to education of the physicists, being aware of what is actually happening as such, and clearly help individual patients. But they also help learning and help the overall institution to develop. That's why we don't just ask for replans, but also feed back things into the treatment planning process, even if a particular patient's treatment plan is not changed. If there could have been some improvements, or could have been potentially some changes in workflow or different energies or treatment units used, well, then this might benefit the next patient and might inform what we buy next for our center. Again, last check. Being the last one is that everyone just wants to get on with it and basically asks us to be as quick as possible. And there is, on the other hand, we would expect also that there are the least number of changes required. We still find about 1% of treatment plans where the physicist can help improve patient treatment and hopefully patient outcomes. And I do think that this is important. So in summary, I think I can end up by saying treatment plans are key documentation in radiotherapy. Checking them is absolutely essential, and you can sort of see that the physicists interact in that patient pathway on many, many, many different locations. The plan check is only one of these locations, because physicists bring so many good ideas, so many skills and competencies to their patient pathway that they are really essential. It's not something I need to tell you, but it's certainly something which is worth repeating overall. Automation will allow us to focus on new issues, and the physicists do need to understand not only the treatment plans, but also why that treatment plan looks like it looks, why the oncologist is choosing a particular approach for a particular patient, and potentially also what other treatments this patient has undergone, not just previous radiotherapy treatments, but also concurrent chemotherapy, immune treatments, and so on. It's interesting to sort of say, and I haven't talked about brachytherapy, for example, but if you look at the brachytherapy workflow, this looks very much the same. And the physicist, again, is needed not only in their plan check, but also in a variety of other areas. Where things get really interesting, though, is that the same also applies to other areas of of treatment. For example, in nuclear medicine, in theranostics. And in theranostics, we again see a patient workflow, which we can study, which we can learn about, and we can see that the physicists is required at different positions. And we are arguing very strongly that we can learn from the diagnostic nuclear medicine physicists to the therapy physicists, and the two can really work with each other, learn from each other, because the important task of plan checks is applicable really to all of us. So thank you very much. Thank you to many of my colleagues who have sort of influenced our thinking of treatment plan checking. And I'd like to finish with these two pictures of treatment plan checkers in the medieval or late medieval Renaissance time as such, and would be very happy to answer questions.
Thank you very much, Professor Thomas, for your insightful and engaging presentation. Our moderator is unable to continue the session due to some unavoidable reasons. I'll be taking over from here on his behalf. Thank you for your understanding. Now, I would like to kindly invite Dr. Ahmed Shoaib, Associate Professor and Consultant, Department of Radiation Oncology, Menufia University, Egypt, our panel of experts, to share his valuable insights and remarks on today's session. Dr. Shoaib.
Well, first, I would like to thank Professor Kron for his very educative and nice presentation for this important topic in the field of radiation therapy. I would just highlight the point that we have in some centers, there is complete dissociation between the hospital information system, the HIS, and the system we use for planning, whether Eclipse or any others. And for this specific situation, it is a little bit difficult to automate some things like collection of data and like integration or generation of reports. So that would be a challenge for people who do the scripting and for people who collect the data. I would like Professor Kron to highlight how can he overcome such points if he has insight in that.
I think you're making a really, really important point. And I tried to highlight some of these aspects by looking at multi-vendor environments. And that is indeed a significant problem. However, I would argue that already things like a treatment planning system is a large enough microcosmos to make scripting or some sort of automation valuable. Even if that then just exports some information in a sort of list, like a CSV file, which then someone can take manually to the hospital information system and compare, yes, this is the right patient. Yes, the age of the patient has been properly transcribed. Yes, the previous treatments have been properly transcribed. It is a start. We should, however, try to encourage vendors more and more to try and help us with that task of trying to minimize double entry of information and automate as much as we possibly can. We do not have everything automated in our institution as well, and but it is something where we have at least tried to get on the path towards.
So what is the one area of the plan checking process that despite advancement in automation or AI, you anticipate will always require significant human reasoning and oversight?
This is an excellent question, and I don't think it can be answered in a simple way. From my perspective, it is that trying to understand the objective of the treatment. What is it the oncologist is trying to achieve? And then bringing the physics knowledge into that and trying to work out what is the best way of achieving that. And the oncologist will not say, use 10 MV X-rays, or the oncologist will not say, you have to come from these 7 angles. No, that is then something the physicist would then say by saying this is a pediatric patient. For the oncologist has the main objective of trying to minimize the overall dose. So the physicist could understand that the oncologist is concerned about cardiac toxicity. It is all these clinical bits which the physicist then can check and embed in the treatment plan. And I don't think that is something we will see in AI being able to do in the foreseeable future.
Yeah, you're absolutely right. We have a weekly meeting in our center where we revise all the new plans or all the patient data. We get all the oncologists, radiation therapists, physicists all together. We revise all of the plans for this week, the new plans, and we discuss about every point and insights from everyone. But let me ask you specifically on how are insights derived from identified issues, even if minor or not leading to a full replan, systematically translated into actionable changes, such as updates in policies, optimizing settings, or educational initiatives for the multidisciplinary team?
Yes, this can be in a very simply, it could be that we achieve all the planning objectives. So all the constraints are met in a treatment plan, but the plan could still be better. So, for example, let's look at a prostate cancer treatment. We get the anterior rectal wall dose just to pass, but we also give a very high dose to the posterior part of the rectum. The treatment will be delivered because it is considered safe. However, it is unnecessary to give that high dose at the posterior part of the rectum. And maybe future patients in a retreatment scenario or in getting a secondary cancer can benefit from that additional sparing. So we would feed that back, and then the planners next time would sort of say, "Oh, that's an easy thing to change." There are lots of these small examples. Cardiac doses is something we are looking at. We are feeding back, for example, organs which we may not consider at all as such, like esophagus is obviously one, but also thyroid. In a young patient, do we need to give unnecessary dose to the thyroid? Probably not. Is it recorded in the treatment plan as a critical structure? Probably not. But we can look at the overall plan and look at areas of improvement.
Let me get that question from the chat by Ali, who's asking, can we create a self-learning radiotherapy that continues time patient data, automated QA, and adaptive planning without human intervention? Nice question.
I think that is really the question at the heart of everything. Lawrence Court at MD Anderson Hospital, they are working towards some sort of automatic treatment planning process which can improve itself and look at predicting plan quality, checking how close are we getting, looking at gaps and so on. So yes, I think it is possible, and it's something we can probably at least get to a point where it can look at all the technical aspects as such. Will it be able to also take into consideration that the patient lives 3 hours drive away and will not come to the additional fraction which is just scheduled on a Monday? Probably not. So I think there is still this human interaction, and something which I think in these weekly rounds would be looked at, which may still take many years, if at all, to become widely available. It also is sort of a question of how quick can these feedback loops really be?
Yeah.
Can the feedback loop from one example, which is sort of we've seen, for example, in rectal cancer, towards the end of the treatment, the patient gets some initial toxicity and they become more unstable. How do we capture this sort of information in fully automatic process. The RTs can provide that information back, and we can then sort of say, right, we may need to do more image guidance, or we may need to increase margins, or we may just need to give a bit of pain relief or a sedative. So yes,
So the clinical
would love
judgment
it,
is always there.
but the clinical judgment is still there, is always there,
Yeah.
and I think
Yeah.
it is really what I'm trying to say is that the physicist should be part of that clinical judgment team, because we have something to
Yeah.
add to that.
Yeah. So going to the defense in-depth concept, how does PMCC foster seamless communication and collaboration to ensure that the specific physicist insights are optimally integrated into the overall treatment planning and delivery process? Do you have a specific formal mechanism or team structure in place to leverage this specialized knowledge effectively?
I wish I had. I think I can give you a standard answer, but it is what we have tried to do is embed a physicist in each of the tumor streams. So that basically means that the physicist would become sort of a bit of a subspecialty person. So I, for example, support the lung tumor stream and the breast tumor stream. So I would know about the role of immunotherapy in lung cancer. I would know about the lung screening, which may impact on our stage distribution, and so on. And I would sit in meetings with the lung oncologists and the lung treatment planners and try to provide that feedback. So does that work?
Is it the site?
Well,
Is it the site of treatment which is more important, or the intention of treatment? So if you have a lung cancer with a palliative intention, I think that differs from lung cancer with
of
radical
course.
intention.
Yes. It certainly does. And oligometastasis, which from a breast cancer or from a colorectal cancer may or may not be the same thing, even if they happen to be in the lung.
Yeah.
So I agree entirely with your question, and I don't have a good answer, but I think what we need to try and do is get as close as we can to the clinical team.
Okay.
And but I don't have a
That's fair enough.
good answer.
That's fair enough. Okay.
Yeah,
So
Professor Swaib, we have summarized all the question in a PowerPoint slide, so we will go for the question and answer session. If anything else you can say, then you can.
no.
Yeah. And your valuable contribution to today's session. So now we will begin to our question and answer sessions. Can you share, Zubair, please? Yeah. So can you see the screen, Professor Thomas? These are the questions.
Yes, I can see the screen.
Yeah.
Why QA is non-negotiable in Australia? Because the regulations say we do need to do it, and we do not get reimbursed if we don't do QA. It does not mean that it's negotiable in other parts of the world. No, it's the opposite. I think it's the right thing. It should be non-negotiable everywhere. QA should be just an integral part of that. I'm sorry if that came across that it could be negotiable in other parts of the world. I certainly don't think so. I just don't know if it is negotiable in other parts of the world. I'm in planning. Are there documented policy accepted worldwide? There are clearly guidelines, but what can actually be done is different if you have a halcyon treatment unit or a cobalt unit or a gamma knife. It depends obviously on the organizational center. It depends on the experience. It depends if you can treat, if you have a very good brachytherapy department, you may prefer to treat many prostate cancers with brachytherapy rather than external beam therapy. So there is no uniform answer as such. But a good thing to look for is probably clinical trials protocols, because they typically give you at least some guidelines as to what are the typical plan qualities you would expect to see. What should the dose be for V20 of the lung or whatever there is. There is, I don't think there can be a unique policy unless you are participating in a clinical trial where this is really prescribed very tightly. Does that help?
Yes. We can proceed for the third question. Can you please suggest steps for plan check for a patient with motion management right from 4D CT till treatment?
I think that the most important thing is to actually have a physicist at 4D CT, if that's possible. And obviously that's not always the case, but the motion management starts probably before the 4D CT. It starts with looking at the patient, checking, can the patient, is the patient a regular breather? Can the patient hold their breath? We would often prefer moving patients to a breath hold technique rather than a gated technique for a variety of reasons, and see is the patient, do they have any problems in their breathing? Then the 4D CT needs to be looked at, and one needs to sort of see, is it does that 4D CT really represent the patient as we expect the patient to be at treatment? And then it is a question of what motion management tools are available, from compression to ITV construction to gating to breath holds, and then seeing that through to treatment, and ensuring that you have some sort of documentation from the treatment plan, which can then be checked in the treatment as well. We are fortunate to have 4D cone beam CT on the treatment units, so we can actually verify that the motion is identical. But a normal cone beam CT can also do that by just showing you the average of the position. So lots of steps, depends very much on the type of motion management.
And how to manage big data in a radiation oncology medical physics department, and what checks do you suggest? How much secure is the cloud? That's an important question.
That is a really important question.
Yeah.
And I cannot answer that, but my understanding is that Australia has regulations that patient information can only be in a cloud that is, basically a file server farm, which is located in Australia. In general, the cloud solution providers have better tools to ensure data security and backup than we could do in the hospital. But that depends on where you are, and having data in the cloud actually can be quite expensive. As such, it's not necessarily a cheap solution. It is really up to the physicist to check or to contribute to a discussion about security in the cloud. And very important in that context would be disaster recovery or business continuity, which basically means what happens if a connection breaks or if some disaster happens in the cloud. How quickly can we get our data back?
So let's proceed to the fifth question. In your experience, sir, in a multidisciplinary setting, how do you manage workload and plan check in a combined check between medical physicist and radiation therapist?
That's a really good question, and that was at the heart of our of the work we did when we reviewed our processes. I think the most important thing is to talk about it and to see what each other is doing, and then sort of try to work out what is best done where we ended up with a modified treatment check process, but it is really up to every department to talk to everyone in the multidisciplinary team and identify what is best checked by whom. And that unfortunately also includes how many people, qualified people, do you actually have? It may well be that an oncologist may need to do some checks which otherwise would be done by a physicist.
Yeah. So thank you very much for the nice and wonderful discussion. As we come to the conclusion of today's session, I would like to extend my heartfelt thanks to all those who made this event a success, to our distinguished speaker. Thank you for your sharing and expertise and perspectives. To our panel of experts, we deeply appreciate your valuable insight and reflections. And most importantly, to our global participants, thank you for your active engagement, thought-provoking questions, and your commitment to advancing cancer care globally. This exchange of ideas and experience from around the world truly reinforces the spirit of the collaboration in radiation oncology and medical physics. Please note that a recording of this session and the certificate of the participation will be sent to all registered attendees in the coming days. We are also pleased to announce our next webinar, which will be held on 21st August of the upcoming on motion management in radiation therapy. The upcoming session will continue our educational mission with another timely and impactful topic. We warmly invite you